Good morning, everyone, and a very warm welcome to UNU-IIGH. This is the first of our seminars in the Gender and Health Seminar Series. So I'm hoping we will see lots more of you. UNU-IIGH, the United Nations University International Institute for Global Health, is one of 14 institutes in the United Nations University system. With a mandate to build knowledge and capacity for decision-making by UN agencies, UN programs, and member states about global health issues. We do this through the translation of evidence to policy, drawing on our convening function as the UN's think tank specifically for global health. And also through the generation of policy-relevant analyses, the focus of which is this seminar series, What Works in Gender and Health, and through strengthening capacity for local decision-making by developing knowledge products and conducting demand-driven training programs. I won't go on too long because we have two amazing speakers. We're really privileged to have them open up this series. Professor TK Sundari Ravindran, who holds a PhD in applied economics and served for 20 years as Professor of Public Health at the Menon Center for Health Science Studies in Trivandrum. We have the privilege of having her as one of our visiting senior fellows, principal fellows here at IIGH. And we're making sure that we can milk her for every last bit of enthusiasm and energy that she has to continue working in the area. And our second speaker is James. What's James? Oh, happy. Okay. Our second speaker is James Lang, who is a senior visiting scholar here again with us. He used to be with UNDP, and again, he brings a lot of his knowledge and experience working across the UN system. Our work, as we engage in this series of seminars on gender and health, as I said, I hope we will continue to see you here. The focus is really on trying to find out what works and how we can engage with the ideas. We would like to make this as interactive as possible. And I presume you're coming partly because you have some knowledge to share with us in the area, but critically for us to be able to translate this work and do something with it, other than have fun together and have macan afterwards. So listen and engage and ask questions. We can continue that engagement as well over lunch. Welcome again, and I hope you enjoy the seminar. And we're starting with Sundari. Thank you.
Good morning, and it's a privilege to be here among all of you. And what I'm going to share today is work ongoing, recently written up, but would really appreciate your comments and insights before I finalize it. So it's on sexual and reproductive health services in universal health coverage. It's a review of recent evidence. And so this, you know that both these, that universal access to sexual and reproductive health services and universal health coverage are both hot topics. There is a lot of interest in making sure that as people move forward with universal health coverage processes and plans within countries, that sexual and reproductive health services get their due place and priority. And the presentation I'm making is based on a review which was and is meant as a background document that the World Health Organization intends to produce as a handbook of how countries may go about including sexual and reproductive health services. So it's initial work. And the main objectives were to explore what do we know about universal coverage of SRH services, where are we at, and the extent to which when countries are planning for universal health coverage, holding discussions and decision-making bodies are set up, what place has sexual and reproductive health actors found around that table, and where is it being prioritized? Now, I think to this audience, I probably don't have to explain why it is important to prioritize sexual and reproductive health services and universal health coverage. So we are doing ICPD plus 25 this year, and more than 25 years ago, all the member states of UN committed themselves to universal access to reproductive health services, defined including sexual health services those days for political purposes. When they said reproductive health services, they included sexual health services within that. And that commitment was standalone in a sense that in order to achieve sexual and reproductive health coverage, you need strong health systems. And I think we are in a better position today that there are two SDGs, 3.7 and 3.8, one talking to universal access to sexual and reproductive health services, and the other talking to universal coverage of health services. So backed with the commitment to improve and strengthen health services, I think this offers us a window of opportunity to push our agenda forward. So that's one reason. There's a lot of literature on how and why sexual and reproductive health services offer good value for money, because when you work on adolescent sexual and reproductive health, you're actually, for example, improving maternal health, you're improving contraceptive practices, you're preventing HIV and STIs. So it makes very good financial sense and economic sense to invest in this. And the other 2 points are that there has been very limited attention to SRH, and the progress has been checkered over the years. We haven't gone really very far, and that there have been some unique political challenges to realizing sexual and reproductive health and rights and advancing sexual and reproductive health services. We know that we are still struggling to keep to ICPD commitments 25 years down the line. What does this review look at in terms of components of sexual and reproductive health services? It's a whole range from maternal health to cervical cancer and breast cancer. This was listed in the ICPD program of action. And in the universal health coverage, I'm sure everybody is very familiar with the universal health coverage cube, which talks about what proportion of the population are covered with what range of services and receive financial risk protection, which means that they don't have to pay at the time of receiving services for those, such that they don't have to be denied services or don't have to worry about seeking services just because they don't have the money in their pocket at that particular time. So this inner cube is where countries may be at, and the intention is to reach the larger, fill the cube. And in the review, the dimensions of universal health coverage that were addressed was financing of sexual and reproductive health services, developing essential packages of health services, engagement with the private sector providers, service delivery challenges that are unique to SRH, and accountability mechanisms. Why did we do that? We started off looking at studies that were talking to our main question of what is happening in countries, where are countries at vis-a-vis universal coverage of SRH services, and what are they now doing in order to move the agenda forward. And we found there's pretty little about this. And therefore, we had to go into the fragmented evidence available on each one of these topics separately, and then stitch together a picture of what exists, and that's what I'm presenting. This has been a humongous task, and I'm still in the, seeing the trees for the woods, and would appreciate whatever you can contribute to culling out the essence. So what's the overall picture of financing sexual and reproductive health services? Now, you see that I have given 2012 picture. That's we do have for 2014 and 15, those are estimates. These are actual figures, and those are the latest. What do we find? That it is actually out-of-pocket expenditure of households that contributes 2/3 of financing for sexual and reproductive health, and that actually, there's a lot of literature on donor funding and how it needs to be increased, but nobody is really talking about need to move away from out-of-pocket expenditure. Governments in most countries are the second most important source, and international public funding comes third. And this aggregate picture holds for most countries, but there are exceptions. There are countries where after out-of-pocket expenditure, the most important one is donor funding. Now, why is this cause for concern? Because from the perspective of universal health coverage, this is one of the least desirable forms of financing. It will deny people access to care when they need it most. And to move towards UHC, countries have to replace this form of financing. What am I doing that's wrong? Okay. And even we have a lot of studies, but focused only on maternal health and to some extent on safe abortion, about the extent of out-of-pocket expenditure. And we know that it's leading to catastrophic health expenditure, which means households that are paying for this are denying themselves some basics. And it's much prevalent in the poorest households. Okay? Now, where's international public funding going? Now, USAID is the major funder. It was then, it is now, although it has cut a lot of funding, continues to be the major funder in terms of public funding, bilateral. But from 2000 onwards, the share of family planning services in this whole thing has been falling. You see that HIV account and STIs account for 65% of the funding, and followed by what is called basic reproductive health services, which is essentially maternal and child health care. So when we get these figures, please be aware that they are talking about a limited range, what is called costed ICPD package, and it consists of just these 4 things. We are not even talking about any of the other SRH services. There is no data. Now, government funding is very important in many countries, and these, I think an important point is that the international public funding has been fluctuating violently in many countries. So this year you get 10 million, 15 million, next year you get less than 1 million. 3 years later you get again 10 million, and so on, which can be devastating for country health systems. You really don't know what to expect and how to plan. Government funding is very important in many countries, even though not adequate. But even here, what we find is that there's fluctuation from year to year, And even when government funding for health increases, they may reduce the allocation for sexual and reproductive health, depending on which kind of government is there and what is the nature of advocacy and push for SRH services. In many countries where there has been consistent funding, and this, when I say many, I'm talking about 4 or 5, that's the nature of information that we have on this. When there has been consistent funding into social health insurance schemes, into other prepayment schemes, they have found utilization going up and out-of-pocket expenditure coming down. Many countries have also started publicly funded health insurance schemes for poor. In fact, they are not insurance, they are some kind of social protection schemes. And these have helped expand utilization, but the few studies that exist say that there are problems in terms of enrollment of women and men, older people versus younger. So there are limitations in terms of design of these and in terms of implementation that needs to be looked into. It's a huge amount to cover, so I hope I finish it. The next aspect that we looked at is private sector engagement for SRH provision, service provision. And more than other areas of health, it looks like sexual and reproductive health services has attracted much more attention in terms of how to engage the private sector. Many donors are prioritizing this, and there has been experimentation with various innovations. And the modalities have included social franchising schemes. I'll go into the details if somebody needs to know more. Social franchising is a whole network of private providers who may be funded by government, they may be funded by donors, and they are meant to expand access to care. Then there is social marketing, which we know, usually done for contraceptive products, but also some other products. Then many governments are contracting with private providers so that there is expansion of access, and there are also voucher schemes. All these are meant to expand access to care, including for underserved. So what do we mean expanding access? So we need to reach the underserved. And voucher schemes are also intended to provide financial risk protection. People don't have to pay for services at the time of receiving care. There have been maybe much more written about this whole area, and there are many systematic reviews that have looked into these, and they report that they show promise because most of the studies are weak evidence. They do not necessarily expand the range of services available. They've been providing maternal health and family planning for the most part. And they also charge for services except for the voucher schemes, and therefore they don't necessarily reach the poorest. Contracting with the private sector was meant to reach the poorest in many countries, but you know that private for-profit providers exist where money exists and where there is demand. So you're not creating new providers, you're using those who exist, and therefore they're not really in the most remote areas. So the main conclusion one can draw is that we need more robust studies. We have very weak evidence of what can happen, and we need studies that look at whole of system impact. Where are we going with these? Does this really increase population coverage? Because the studies that are now there are only looking at what's happening within specific projects. Now, for example, utilization has increased in Project X. Now, is it a shift from government to this, or are these new users? Now, unless we know that, we don't know what their potential is for universal health coverage. Now, the most important, a lot of attention has been paid by SRH actors to making sure that essential packages of health services have SRH services included. What are these essential packages? They are packages that governments want to provide free at the point of service delivery, or at very subsidized rates. And they are a priority range of services because you can't provide just about everything. The data on this is scattered. The essential service package is known by many different names. It's known as the core package, the minimum package, the basic package. Sometimes there is no package, but it's spelled out in standards of service provision at the primary, secondary, and tertiary levels. And so I had to look at basic information available, helped by a series of snapshots provided by USAID on RMNCA-H services in EPHS. But I had to work backwards to find out other SRH services, and this is the result. Once again, what we find is that MCH and FP are there, maximum, but there are also many other interesting, including reproductive health reproductive cancers. You have even gender-based violence, infertility in the essential service packages. But you dig further and you find that these were supposed to be commitments by governments, but these have remained aspirational in many countries. So it can be in the essential service package, but there's no program that, there's no program backing it up. And it's been there for a long time and it's not moving any forward. And there's no money backing that. So it doesn't really make sense to look at EPHS. Maybe what we need to look at is health benefit packages, which are packages with assured financial mechanisms. For example, included in social health insurance, or it is definitely part of government services in government health facilities. They've been funded for, there is a budget for it, or that there is donor funding for it. And so what do we find? There's very limited information, and the information that we do have shows that all those other aspirational things don't exist in HBPs. What we have is again narrow range of maternal health services, including though obstetric emergencies, and even family planning services, contraceptive services are not always part of social health insurance schemes. They are supposed to be provided free in government health facilities, donor funded or government funded, and many countries report that these may not all be available. So this is, in effect, most SRH services have to be paid for. Out of pocket is my inference. Who is involved and how do they decide? The information that we have is from 16 countries, and what we find is that mostly it's top-down exercises, technical experts, both national and international, policymakers, of course donors are sitting around the table. A few countries, 4 countries that I could count, have involved communities and civil society actors in quite an exemplary manner in terms of improving their capacity, better informing them, and engaging them. And there's something to learn from there. The 2 studies, which were very interesting, one on Ghana, and it said that, in fact, when EPHS was being developed, the SRH actors were not really interested in participating because they had well-funded vertical SRH programs. They wanted to protect their territories. And then the EPHS was developed based on burden of disease. A lot of sexual and reproductive health services were left out. And, so this may be the situation also in many other countries. It's not clear that SRH actors are, when I say SRH actors, beyond civil society, even those who are working on it as researchers, and the departments, health departments concerned and so on. There's only one instance of CSO participation in health benefit plans for national health insurance from Zambia. All we know is that they got involved, they are pushing for SRH services. It's a fact sheet, doesn't tell you anything more. We also looked at service delivery challenges that are unique to SRH services, not the usual human resources and drug supplies, so on. That is common across the board. But what's unique here is that there are many policies that deny services. There are also human rights violations that happen on a routine basis that nobody seems to be bothered about. And there is, because of gender norms, which permeate also the health systems, there is denial on the ground of many kinds of services, and also demand is affected. So one of the things is that if you want universal health coverage, then you have to move the agenda on policy reforms and on more gender responsive health services. That's also part of the UHC agenda, not usually recognized. The last is accountability mechanisms for SRHR. There are many, and we need to know about accountability mechanisms because so many promises have not been honored, and we have to have more effective accountability mechanisms. So over the past 25 years, human rights treaty bodies, other human rights bodies have played a very important role. For example, as part of the Universal Periodic Review, which is about human rights situation overall, about a quarter of them did mention, and this is a good friend who has done this review, about a quarter of them had recommendations on SRHR, and many countries actually implemented those. So seems like that's an area where there's a lot of promise. Many attempts are going on for tracking progress. It had been there, there's Countdown 2015, FP 2020, so on and so forth. And also now for the accountability for women's and children's health and SDG reporting. We don't know the extent to which they are having an impact. There's also studies on performance at the national level. On performance accountability, this is like how are health systems faring through surveillance, through maternal death reviews, through quality assurance, and so on. There are many social accountability initiatives which are from communities and civil society. There are also some examples of legal accountability where people have gone to court to establish their constitutional rights or to fight against rights violations. But in published literature, there is much more on social accountability than on other kinds of initiatives. They have been mostly descriptive. They say what is being done, not why they do it in that particular way. And there have also been very few objective assessments of outcomes, of are they working, and except, they say there are implementers' accounts that yes, things are improving. But there's not a kind of objective studies that tell you because of this, these are the outcomes and these are the indicators. The most important thing is that we don't know what works where and why. We know, and accountability mechanisms are definitely not one size fits all. They are very context specific. And we didn't come across any social accountability initiatives for advancing SRH within universal health coverage, specifically with that intention. So I'm with what do I think is the agenda for action coming out of this. One, that high levels of out-of-pocket expenditure and catastrophic health expenditure is an area we need to pay attention to. We need to move towards financing through other means that are not out of pocket. We have to make sure that international public funding is for a comprehensive range of SRH services, not just maternal health and even less family planning. Most importantly, that they are stable and sustained over a period of time. There is now a move to go to more towards loans at market rates. and we need more grants and concessional loans than loans that have to be, private loans that have to be repaid at market rates. We also need advocacy for greater priority for SRH services in government health budgets, including but not limited to. So I'm not saying we've achieved everything we need to in MCH and FP, but we haven't gone beyond that. So we need a larger, package. There's need to push for civil society participation in country processes for development of EPHs and HBPs. One important thing that I would tell here is that we need greater alignment between the essential services of health service package and the health benefits packages. One study, only one, found that there was a 30% alignment, that only 30% of what was in EPHS was in HBP in 22 countries. Then the main, in terms of accountability mechanisms, they are all over the place, even within countries. Many interesting things are happening, but nobody is coordinating with anybody else. They're not building on synergies. They're not strategizing innovatively. They're not, all focused on this area that we are interested in, how to advance the SRH agenda. They may be looking at subcomponents of it, each one doing their own. Most importantly, evidence building is an urgent priority. What I found was that there's a vast body of work on UHC, thousands and thousands of publications that one had to scan through, barely touches on SRH. And there's also a lot on SRH literature about universal health coverage. What do they talk about? They keep talking about why it's a priority. They don't tell you what is actually happening on the ground. They don't tell you what needs to happen, but they say it's important that we do it. And really doesn't lead you much further. We need studies that use rigorous study designs, and they need to examine system-wide effects. That is, what's the contribution of this to universal health coverage in terms of which underserved population groups, which hitherto unavailable services coming in? Are we reaching out to new providers or existing ones? We need to understand the processes and pathways. Why is something working here and not somewhere else? How did they come about, how did this country succeed and not some other one? And we have to factor in the global and national contextual factors that are specific to SRHR. So, very different from things that affect universal health coverage. We have opposition to a whole range of sexual and reproductive health priorities by national governments and by international actors. And these affect what is possible to achieve within countries. But studies don't seem to factor these in, or they don't tell you that it didn't work in this country because of this reason. So that's where I leave you. Thank you.
Thank you so much, Sundari. Do you want to stay up? Because we're going to take some questions for you.
Do I have to stand there?
Yeah, I'm just going to speak in the microphone because we also have some colleagues online so that they can hear, right? So hello everyone, my name is Michelle Rame. I lead the pillar here on generating policy relevant analysis and research. So welcome again to UNU-IIGH. We are going to take about 15 minutes to take some questions, comments, thoughts, contributions from all of you based on Sundari's excellent presentation. So let me open up the floor. Does anyone have any thoughts? Yes, Kristen, go for it.
Hi. Sundari, thank you so much for a very informative presentation, and I'm so excited about your research. Just two questions. One is, in the context of sub-Saharan Africa, 40 to 60% of the healthcare delivery in many situations is done by faith-based organizations. So I'm wondering, in your analysis, did you take a look at how the core values of faith-based organizations may be impacting the ability to incorporate SRHR terms of universal health care coverage. So that's one question. The other one is, when we're talking about accountability, I've moved between both the health and justice sectors, and I find that these two sectors are not necessarily talking to each other. And I think these are missed opportunities, especially when we're looking at research. There's some interesting work going on that the UK is supporting through the FCO under an initiative called PSVI, the Prevention of Sexual Violence and Armed Conflict. Physicians for Human Rights has done some really interesting work in the context of Congo and other areas, looking at how to link accountability to SRHR programming. So I just mentioned that, and I just think that this is an opportunity for us to perhaps engage and think about some research across those sectors. So I just wanted to make that point.
Lenny,
Yeah.
maybe
I have a follow-up on Kristen's question on the faith-based organization. So my question is on foreign policy. How has faith-based organizations influenced foreign policies and then consequently U.S. Development funding? So you said that U.S. is the major donor for SRI. I was wondering if you could comment on that level as well.
Yeah. So in terms of faith-based organizations, I did look for published studies on this. There is some breakdown for a few countries about what proportion of the service delivered is by faith-based organizations, but not much more in terms of services that they would fail to provide because they are faith-based. So that's one part. The other is that I did look at journals like Health and Human Rights, and also on litigation and so on. There's a lot about litigation within the United States and in Europe using human rights mechanisms for, advancing certain sexual rights against discrimination and so on, but we were focusing on low and middle income countries, and there we did find, I didn't present the legal accountability literature, limited to a few studies, but they did talk about what was happening. In terms of foreign policy, there are a couple of studies from the United States, from people who used to work in USAID, about how funding has fluctuated from regime to regime. The Kenya example that I put up was really between, the Bush and the Obama periods and so on, but they don't spell it out like that. And I don't want to extend beyond what they said. And again, there are fact sheets saying we do X, and I have even tried to include that, but they don't tell you much more than that.
Anyone else? Yes?
I thought it was really heartening to see that the Universal Periodic Reviews actually do have an impact on some of these areas. Is this research that focuses specifically on accountability within those areas, or is it it just happens to be something that is mentioned? Is this a potential area that we can open up to look at?
I do think this observation is based on a presentation in a previous WHO meeting by Ranjani Murthy, who looked at various UPR reviews originally, and she hasn't published that work. So she looked at it, and then she found how many of those were, for the past X number of years, and then came up with that information. And it does merit more in-depth, looking at which countries, what was actually implemented. And she also gave one counter example of in Philippines, how the recommendations were all positive. At the country level, they got a small proportion of what was recommended, but she counted that as implemented recommendations, So many things that were recommended were not implemented, or were not implemented in the intended way, but at least something was, like the reproductive health policy went through. So yes, it's an area I think here is a 10-year or 20-year research agenda, actually.
Absolutely. I don't see any hands. Do we have any questions online? Okay, we have some colleagues joining online. Yes, please, go ahead.
Hi, I'm Lisa. So we work with marginalized communities, over 100 communities, mainly the indigenous. And our focus is actually to provide basic needs to the people. One of the areas that we realize is on SRH, so sexual and reproductive health. But when we work with partners, it's not really easy to convince them to actually invest, like socially invest in this area, unless there's a pressing need by the government, or it's like vastly taught, like the recent UNICEF child poverty. So government did something due to that. So if there's like a widely published research, maybe by UNU or some other legit organization, would help us to get more funding, because there are so many things happening on the ground and they need it, but they just have no access. So I'm interested to know about social franchising as well, to know where we can get grants or loans to help access to that. Thank you.
This last question, I'm not the best person to answer. I don't know much about that. But I do know that working in a particular area and research in an area is like a chicken and egg problem, always. There's no research, therefore there is no money to, do something about it. There's no money to do anything about it, therefore there is no research. It keeps going like that. And I think we have to break that cycle somewhere. We do a lot of lip service to SRHR, I think. And I was appalled at the limitation of the evidence, in fact. I thought I was going to bring myself up to speed, learning about everything that's out there, but not enough.
My name is Sudin. Thank you for the talk. I have a question with regards to the methodology. You mentioned that the government spending in the overall picture of financing health SRH was about 22%. Could you explain a bit more about how you arrived at that percentage, given that,
I'm quoting secondary sources.
Okay.
And this is regularly computed by UNFPA along with a partner working, it's called, I think, NIDI. And they have taken a limited ICPD costed package of services and whatever data exists from within countries. Country level information on this I could find for 9 countries only. What you call reproductive health sub-accounts as part of national health accounts may exist in many other countries, but have not been published or not even available on country websites as available. So that's very, so we need reproductive health sub-accounts for many, many more countries, but also with more standardized definitions. India looks only at maternal health and family welfare or whatever, family planning. Some other countries look at only something else, and then you can't compare across those countries about what's. So,
is it different in Western and European kind of health systems where they have a more standardized framework?
But I haven't seen published data even from those countries about how much is spent on these. I mean, WHO has produced a guidance for countries on producing RH sub-accounts more than 10 years ago. I think immediately there was a donor who pushed a few sub-Saharan African countries to do this. And in India, there are too many health economists, so we do keep doing RH sub-accounts, various sub-accounts, NCD sub-accounts. So, so it's like some places there was donor-driven, some places it is academic interest that, and really not part of policy.
Is Malaysia with the country that have the sub-account?
No. They may have the data. They have not published it. Knowing Malaysia and also your, very good public health institute here, that advises government, I'm sure they have the data and they can come up with it.
Can I just ask one more? How many countries were included in your sample? Was that?
It's not, mine was not a sample-based original computation. Mine was a review, literature review of, I didn't go into that methodology because I started thinking I'm going to do a scoping review. That was really not possible. Then I had 7 research questions, and for 7 research questions, each one of them, I went with each SRH component, with each UHC dimension, did a keyword search, came up with a whole lot of documents, scanned them, put them together. So it was a very eclectic kind of methodology that suited the purpose.
Any other questions or yes?
When we speak about sexual I'm very curious to know about one of the most marginalized groups, which is usually the transgender community. So in this study, when you compare between countries, I'm curious to know which are the countries that do include the transgender community in the sexual health. Because I'm very sure in Asia, it is not so.
As part of government policy, I really, did not find written up literature. The review did not include HIV literature because that would be another huge enterprise on its own. So I should have mentioned that. I'm really sorry. So maybe in the HIV literature, I'm sure there is much more on which communities of sexual orientation and transgender identities have been considered. And again, it's for HIV service delivery. We don't know about financing. That I'm fairly sure. We don't know what proportion goes to the marginalized communities. We don't know that.
Okay. All right. One more question. Go ahead, and then we'll hand over to James.
Hi, good morning. My name is Dorian. Thank you so much for your presentation. So part of my question has actually been answered, but I just wanted to ask, does any part of the literature that you were looking at reflect the changes in SRH services provided or funded coinciding with the rise of conservatism worldwide?
All we know is that there is a lot of fluctuation, both internationally and within countries. I think we need to match that against which kind of government. There is a hypothesis that this definitely is aligned to the nature of political support for SRH at a particular time, but we need proof. So, very easy to find, but we need to spell it out. Thanks.
Thank you. Thank you very much. One more time.